And now I have the pleasure also to introducing the next speaker who's going to tell us everything we will ever wish we knew about TTR amyloid as hematologist. So Dr. Laura Obici from the Fondazione Policlinico San Matteo in Pavia, Italy.
So, good morning, everyone. And first, I wish to thank Professor Zonder for this kind invitation. It's really a great honor to participate in this symposium. So, in my presentation, I will try to briefly discuss some recent advancements in the management of transthyretin amyloidosis. And I will try also to highlight whether these new learnings in ATTR field may be relevant to hematologists dealing mostly with light chain amyloidosis. Sorry. These are my disclosures. So I want to start with the short clinical case because it's quite representative of a situation that we are increasingly facing in our clinical practice. So this is a 73-year-old male patient that was referred for suspected AL amyloidosis. In his past medical history, it's worth mentioning surgery for bilateral carpal tunnel syndrome, age 65, but also treatment for trigger finger and rotator cuff tear. He has a well-known IgG lambda gas since the age of 58 years that was stable at hematological follow-ups. And a few months before referral, he started complaining of dyspnea on exertion, and he underwent a cardiological evaluations that showed changes in ECG that were not previously reported, and on echocardiography, increased mean left ventricular wall thickness with reduced ejection fraction, quite suggestive of cardiac amyloid infiltration. And also MRI was consistent with amyloid infiltration, showing mild subendocardial leg gadolinium enhancement. The patient also underwent biphosphonate scintigraphy, and this examination didn't show cardiac uptake. So the patient was referred for suspected light chain amyloidosis. On presentation, his symptoms were weakness, moderate weight loss in the past year, dyspnea, orthostatic hypotension, and shoulder and knee pain. And on the right, you see the test results. The presence of the known IgG lambda gas was confirmed by serum immunofixation, no monoclonal light chains, normal free light chain ratio, and no significant renal abnormalities, and normal blood cell count, and normal electrolytes. He underwent a bone marrow biopsy showing an infiltration of plasma cell of 8%, and the biopsy was positive for amyloid. So the question now is, what would you do now for these patients? And we have 5 different options. A, demonstrate elevated NT-proBNP to confirm the diagnosis of cardiac light chain amyloidosis. B, no additional tests required. The patient has AL amyloidosis confirmed based on the positive bone marrow biopsy and the negative DPD scan. C, amyloid typing should be performed to confirm light chain amyloidosis. D, lack of family history excludes an hereditary amyloidosis, so no genetic test required. And finally, no additional tests required. Again, the diagnosis of AL is confirmed based on positive bone marrow biopsy, negative DPD scan, and absence of neurological symptoms. Please vote. Great results. Okay, that's very good. Yes, thanks a lot for. No, yes, this is the correct answer, of course, and this is really what we wanted to hear from the audience, and reflects your experience and knowledge in this field. That's good. We can go back to the presentation. Thanks. Okay, so. Actually, we did amyloid typing in these patients by immunoelectron microscopy, which is our gold standard in Pavia since many years, and actually these patients turned out to be affected by transthyretin amyloidosis. And genetic testing showed an heterozygous clearly pathogenic variant, which is phelan 78 based on the old nomenclature. The patients also had a mild sensory motor neuropathy when investigated by the neurologist, so in the end, he suffered from hereditary TTR amyloidosis with a mixed phenotype, and therefore a gene silencing therapy was started. So I included this case because we all are increasingly familiar with the diagnostic algorithm for cardiac amyloidosis, and some possible pitfalls may arise when we discuss diagnosis of light chain amyloidosis. In fact, the diagnostic algorithm is quite clear. Whenever you have a monoclonal protein, the diagnosis, as was discussed elegantly before, should always be performed on tissue biopsy after accurate typing. And a grade 0 is not specific nor suggestive of AL amyloidosis in itself. So basically, a DPD scintigraphy result is not significant irrespective of its grade when you have a monoclonal protein, because you always have to type the amyloid in tissue. But this case is important to recall that there are many different mutations in the TTR gene that actually do not have a positive DPD scan or PYP scans for reasons that are still not known. Even the most common Val30Met variant, which is observed in the Portuguese population, is not diagnosed, even when overt heart involvement is present by DPD or PYP scan. So this is extremely important to recall. But certainly, bone scintigraphy has dramatically changed our ability to identify and diagnose transthyretin amyloidosis. And non-invasive diagnosis is possible only for transthyretin amyloidosis when two conditions are satisfied: a positive bone scintigraphy with a grade 2 or 3, and complete absence of a monoclonal protein searched by serum immunofixation, urinary immunofixation, and free light chain ratio. So in this case, you can diagnose transthyretin amyloidosis, and the further step is TTR genotyping, to discriminate between the most common wild-type transthyretin amyloidosis, which is typically a cardiac disease that affects males over the age of 70 years, and the variant TTR amyloidosis, which is a less frequent disease but much more aggressive and is typically associated with more systemic manifestations. And this is extremely important to discriminate between the two types, because for variant ATTR we have different treatment options, as I will discuss, and the information is also quite relevant for cascade genetic testing in at-risk relatives. We are increasingly recommending that even males over the age of 75 or 80 are genetic testing, even if the clinical picture and the results are completely consistent with wild-type TTR amyloidosis, because the proportion of cases of hereditary isolated cardiac TTR in late ages is up to 10–20%. So it's important not to miss also this patient's population. So what do we know about the structure and the function of transthyretin? Transthyretin is a transport protein, and its best characterized functions are the co-transport of vitamin A through retinol-binding protein and the transport of thyroxine, particularly in the CSF. The circulating TTR is produced primarily by the liver, whereas the choroid plexus of the brain secrete TTR in the CSF. The native structure of the protein is shown in this picture. This is a homotetrameric protein consisting therefore of 4 identical subunits, and it's important to remember that at the interface of 2 dimers there are 2 tiny symmetrical channels. These are the thyroxine binding channels for TTR, and binding to tyrosine increases the stability of the native structure of the protein. How essential is TTR in human beings is not well characterized. There is no report of complete lack of TTR in humans, and also the protein is highly conserved through a vertebrate evolution. There is a high similarity in the native structure of TTR between vertebrate fish and humans. But on the other side, it's important to remember that the large majority of the protein actually circulates unbound, because thyroxine is mostly bound to thyroxine-binding globulin and to albumin. So whether the native structure of the protein is key for the physiological functions of TTR, we know that dissociation of the tetramer due to destabilization of the protein is the key rate-limiting event in TTR fibrillogenesis. And there is increasing investigations about what is priming dissociation of TTR under physiological conditions. And in recent years, it has been clearly and elegantly demonstrated both by in vitro and in vivo studies that this process is primed by the sequential action of biomechanical forces that expose protease-sensitive loops in the protein and proteolytic remodeling, releasing truncated C-terminal monomeric species that are highly amyloidogenic, much more amyloidogenic than the full-length monomer. We know that proteolysis is quite relevant also in light chain amyloidosis. Here in TTR amyloidogenesis is becoming increasingly relevant because of its highly specific target, because the fragments are quite homogeneous and all start at residue 49, suggesting a specific enzyme playing this role in vivo. And there is increasing studies that show that this enzyme can be plasmin. Plasmin has been shown also in an animal model of TTR amyloidogenesis that is key for the position of the protein in the heart. And when these mice that overexpress a highly aggressive mutant are knocked out for alpha-2 antiplasmin, which is a natural inhibitor of plasmin, the amount of amyloid that the mouse develop is extremely high. So this is quite relevant. It's not yet a target for therapeutic purposes, but may become in the future. Presently, however, our increasing understanding of the fibrillogenesis process for TTR has led to the development of effective therapeutic options that target different steps of the cascade. So, similarly to light chain amyloidosis, we have a class of drugs that suppress the synthesis of the amyloidogenic precursor. And these drugs that knock down both the mutant and the variant TTR are both RNA interference agents like patisiran and vutrisiran and antisense oligonucleotides like inotersen and eplontersen. Both classes exploit endogenous mechanisms for mRNA degradation. So complete degradation of protein mRNA results in absence of synthesis and suppression of circulating concentration. Interesting, there is a new approach to knockdown of circulating mutant and variant TTR, which is under investigation, that exploits the CRISPR-Cas9 technology, therefore providing irreversible gene editing of TTR gene in the hepatocyte. And I will tell you something more later on. The second class of approaches that we have for the treatment of transthyretin amyloidosis is represented by TTR stabilizers. TTR stabilizers are small molecules that selectively bind in the thyroxine binding channels of this tetrameric protein and increase the stability of the tetramer, preventing dissociation, misfolding, and aggregation. Then a third approach that is similar to what has been discussed for light chain amyloidosis is immunotherapy, exploiting anti-TTR antibodies that recognize epitopes that are only expressed on misfolded TTR or on TTR amyloid fibrils. So, as I said, tafamidis is the first in class and presently the only approved TTR stabilizers for transthyretin amyloidosis. It has been approved both for the treatment of polyneuropathy in hereditary TTR patients and for cardiomyopathy, both wild type and hereditary. And this is based on the successful results on the ATTRACT trial. In this trial, it was clearly demonstrated that treatment with tafamidis increased survival and reduced cardiovascular-related hospitalizations. And also the data from the long-term extension study confirm the beneficial effect of patients on tafamidis over more than 5 years compared to patients that were previously on placebo, highlighting the need for early treatment to get the maximum benefit from this approach. And again, even more recent investigations, retrospective investigation in this patient's population confirm the beneficial effect across the different classes, but of course the benefit is higher for patients that start the treatment in NIHY class 1 and 2. Tafamidis is an effective drug in slowing progression of the disease, but its ability to completely stabilize the disease is observed only in a subgroup of patients. And this is particularly true for patients with hereditary TTR, probably because mutations increase the destabilization of the tetramer and therefore reduce the efficacy of the approach. That's why gene silencing agents have been developed and were shown to be particularly effective in this setting. These, as an example, are the results of the long-term exposure of patients with hereditary TTR with polyneuropathy to patisiran. Patisiran is the first RNA interference approved for transthyretin amyloidosis, but also the first RNA interference drug ever approved for any indication, and it has paved the way to the development of this strategy for other rare diseases. And these results are extremely important, and for us dealing with this disease were really amazing when we initially observed the difference after the 12 months of the Apollo registrative studies between the treated patients and the placebo arm in terms of neurological progression. The drug is able to completely stabilize neurological progression over years. These are the longer follow-up available, and the disease remains completely stable, as well as the quality of life is preserved in these patients over so many years. Again, the difference between the patients when the treatment is started early or the treatment is started after a placebo period is striking and remains over time, highlighting the importance of early treatment. And recently we are also looking for novel endpoints. The trial, as well as the trial with enotersen, was quite good for developing new endpoints for this disease, particularly for neurological disease. And this is quite relevant also in the future for light chain amyloidosis, because the new treatment that were discussed before are certainly in search of new endpoints that are independent from the hematological response. And in the bottom, you see the response of neurofilament light chain, which is a novel biomarker for neuropathy. It's not specific for transthyretin neuropathy, but it's quite sensitive and specific and useful for tracking response also in this condition. There are new generation gene silencers in this disease. These are advancements of the platform for the chemical modifications of RNA interference and also antisense oligonucleotides. And binding to these 6 residues, GalNAc conjugates, allows for subcutaneous injection and lower doses and particularly longer intervals between administrations. So presently, patients are treated with vutrisiran every 3 months, with significant suppression of TTR similar to patisiran and substantial beneficial effect on neuropathy progression. And very recently also the data of the new antisense oligonucleotide eplontersen were published. Again, there is significant suppression of the TTR precursor, as you see in the bottom here. and this translates with significant neurological benefit over only 66 weeks. Patisiran has been also investigated in TTR cardiomyopathy, both wild-type and hereditary TTR cardiomyopathy, and the results of the Apollo B trial were recently published in the New England Journal. And the drug met the primary endpoint, that is the change from baseline in 6-minute walk test, and also secondary endpoints of quality of life related to cardiac disease and change in NT-proBNP. But the secondary composite endpoint of death from any cause, cardiovascular events, and 6-minute walking test was not significant. And this was substantially related to the short duration of the trial, because actually the trial was only 12 months long. So in spite of the power effect of the drug in changing the natural history of the disease over such a short period, the lack of more robust cardiac endpoints, according to the FDA, was not considered not sufficient for approval of the drug. So again, we are learning a lot from clinical trial for cardiac indications in TTR amyloidosis in terms of optimal endpoints for cardiac disease. I want to spend a few words on preliminary results from the experience with the NTLA 2001, which is a CRISPR-Cas9 in vivo gene editing drug that is under investigation in a phase 1 study in patients with ATTR cardiomyopathy and ATTR polyneuropathy in hereditary disease. And certainly based on the positive experience with gene silencing that can be provided to patients and suppress TTR for long periods in the absence of any safety signal, we moved forward with higher suppression with gene editing. And more importantly, gene editing is an irreversible approach to suppression of TTR, because it's a once-in-a-while injection that completely edited the gene and results in a robust and persistent suppression of TTR concentration. And as you can see here, after only 4 weeks, the concentration of TTR is reduced up to 91%, both in patients with cardiomyopathy and patients with polyneuropathy, and remains substantially unchanged over long periods. So we are waiting for additional results and phase 3 trial. A phase 3 trial is starting now in patients with TTR cardiomyopathy to see how this additional reduction in TTR concentration translate in terms of organ response. And then before concluding, I wish to address immunotherapy in transthyretin amyloidosis. This study was only recently published and is quite encouraging in terms of the ability of these antibodies to remove amyloid fibrils formed from TTR by TTR in the heart. And in TTR amyloidosis, we have the possibility to track changes by bone scintigraphy as well as by cardiac magnetic resonance. And interesting, only after 4 and then confirmed at 12 months of treatment with this antibody that recognize epitopes that are only expressed on the amyloid fibrils, there was significant removal of amyloid deposition based on these indirect evidences. And this also translated in improvement in NT-proBNP. So it is quite rewarding and suggests that this strategy can be exploited in systemic amyloidosis as well. I'm not entering any more what Giada has already brilliantly discussed about immunotherapy of light chain amyloidosis, where you have also important preliminary data supporting the beneficial effect of immunotherapy in light chain amyloidosis. I just want to provocatively discuss whether light chain stabilizers may also play a role as are TTR stabilizers in transthyretin amyloidosis, in AL amyloidosis. This is much more difficult because of the heterogeneity of light chains and the difficulty to find conserved residues that can be able to bind a stabilizer and prevent misfolding and dissociation. But Jeff Gelly group, the same group that developed tafamidis for transthyretin amyloidosis, is attempting by a strategy, based strategy to design drugs that are able to bind to constant regions identified on full-length light chains in order to form dimers that prevent this light chain from misfolding and aggregation. There are some possible candidates. There is no clinical trial ongoing yet, but maybe this could become in the future a complementary option also for patients with light chain amyloidosis in combination with antiplasma cell treatment. So to conclude, similarly to AL amyloidosis, systemic TTR amyloidosis is becoming a curable disease, although it remains extremely challenging for patients with delayed diagnosis. Available treatment aim at slowing progression or stabilizing the disease through suppression of the circulating protein or stabilization of the tetramer, and immunotherapy is becoming a reality in systemic amyloidosis, as we have seen both in AL and ATTR. Of course, we now need to have more studies to investigate the synergic role of these drugs among each other in order to improve cardiac function, prolong survival, and preserve quality of life. Thank you very much for your attention, and I also wish to thank all the colleagues from the Pavia Amyloidosis Centers, particularly Gianpaolo Merlini, who is my mentor, and Giovanni Palladini, who now is the director. Thank you very much indeed.